delta F508 mutation, and then multiple other possible mutation combinations, including minimal functions. And then the Lancet published a trial that looked at homozygous delta F508 mutations as well too. So this delta F508, or this Trikafta approval, is based on these two studies which were published. Just to highlight here, I don't want to get too much into the weeds in this, but ETI is what we often use as the non-branded presentation for Trikafta. And what this slide shows here is that Trikafta in patients with cystic fibrosis with one delta F508 mutation and one minimal function mutation had a significant improvement in lung function. This is looking at FEV1 here, but almost 15%. That was early in the course of treatment and was sustained throughout the 6 months of this, and was sustained throughout the 24 weeks or 6 months of this trial period. So early improvement in lung function that was sustained. Okay, and I think that's important for those of us who've been doing cystic fibrosis for a little while. This actually looks very similar to the original Kaleido studies or ivacaftor studies in the G55-1D population as well too. The early, very improvement that was sustained. In addition to, while improvements in FEV1 are something that we can see in clinic, something we can't see is improvements in sweat chlorides. And what you see here in this chart is that in addition to improvement in lung function, Trikafta resulted in significant decreases in sweat chloride as well too. In some patients, this reduction in sweat chloride actually resulted in sweat chloride values that were actually below the diagnostic threshold for cystic fibrosis, which is 60. A lot of them would end up in the 30 to 60 land, so that gray zone as well too. But again, what this shows is early improvement in sweat chlorides that was sustained throughout the course of Trikafta treatment. Well, those two things are great, right? But what about patients who have to spend time in the hospitals because of exacerbations, right? Well, Trikafta really excelled, right? Trikafta really achieved great benefits with this as well too. This chart's a little bit different here. And what you see in this chart here is patients in yellow were on Trikafta, patients in white were not on Trikafta. And what you see is the proportion of patients without a pulmonary exacerbation, right? So being in this chart, being on the top yellow line is better. That means that you did not have an exacerbation as well too. And what you see is that over the course of a 6-month period, you have about a 25 to 30% difference in patients who experienced a pulmonary exacerbation during this time period. And pulmonary exacerbations are not only important just because of time spent in the hospital and the risk associated with hospitalization, but a lot of patients, when they have a pulmonary exacerbation, never quite regain that lung function that is lost. And that's really important too. We tend to think of the loss of lung function in cystic fibrosis as a steady or linear decrease. But in fact, a lot of times it's actually it's a large decrease that comes back somewhat, but doesn't come back as high. And it's hard to know which exacerbations may result in permanent loss of lung function. So controlling these exacerbations is important too, right? So now what I wanted to do right there was just take everyone back to the initial approval of Trikafta, why it was such an exciting medication, why it's been such an exciting time since then. And in general, what we're calling Trikafta is a highly effective modulator, okay? We've had other modulators since this time. We've had Orkambi, we've had Symdeko, and I tend to look at those as jumping blocks en route to highly effective modulators. But now we have a highly effective modulator that a significant percentage of the CF population is eligible for. And how does that change? How does that change our treatment? How does that change cystic fibrosis since that time? So a few of the things I wanted to look at some of the real world studies that were done since that initial approval in 2019. I want to look at some of the planned studies, the studies that are planned to look at this question. I'm going to talk about some of the expanded indications in modulators since that time. And I'm also going to look at patients, and I also want to touch on that group that very small percentage of the population that is not eligible for a highly effective modulator currently, and the promising work that's been done is there too. Now, as I talked about before, obviously, as most of us know, Trikafta was approved in late 2019. And shortly thereafter, when these real world studies were going underway, the COVID pandemic hit. And obviously, it caused a major pivot in a lot of the medical trials that were being done too. So the exciting data that we had expected to have at NACFC in fall of 2020, we didn't quite have that data, but we still have enough data that I think we have some exciting things here to show today. So this is a busy slide here, and I don't want people to get lost in these beautiful colors here. But what I want to show here is that, on the left here, we have this chart of patients with Pseudomonas aeruginosa, which obviously we all, as CF patients and families, we follow very closely because of the implication for progressive lung disease, and it has treatment implications as well too. And this chart on the left here shows that in about 33% of patients, just after 1 month on highly effective modulators, their cultures became Pseudomonas negative, okay? And that's exciting as well too. And even in those patients who didn't become Pseudomonas negative, you see these orange colors here, a lot of the density of their Pseudomonas decreased in just 1 month as well too. Now, I think it's important to note that this is just 1 month snapshot in time, but we're excited to see the long-term data that comes from this too. Does this 33% of patients become more stable over time and do not regrow Pseudomonas? That's a big deal. I mean, with regards to progressive lung disease, in regards to treatment burden with other medications they may need from day to day too. And what about these patients who are starting to decline? Well, these patients eventually clear their chronic Pseudomonas infection also. So this is some of the exciting stuff that we're looking at. What about Staph aureus in these patients too? Staph gets a little bit less attention than Pseudomonas as well too, but Staph is one of the very first bacteria that colonizes the lungs in Pseudomonas patients too. And what we're seeing is the same general trend and decreases there also. So I think that's exciting. And I think we'll have more data on that at NACFC 2021 in San Antonio. Patients may not notice chronic signs and symptoms from Pseudomonas infection. It may impact their treatment regimen, but they may not notice symptoms per se. But what about our older patients? I think a lot of adolescents and young adults, and even older adults with cystic fibrosis tend to experience chronic sinus disease as well too. And this can impact their quality of life. So, and I think we have data that for several years we've been collecting data about patients with G55-1D and kalydeco-responsive mutations and the improvement in sinus disease. But now we're able to see this in other patients as well, in a more broad spectrum of patients as well too. And so this picture on the left here, basically this is a CT scan, cystic fibrosis patients and their sinuses. And I don't think what I think is obviously important is these red highlighted boxes here, but I think what you'll notice is on their baseline sinus function on the left there, what you're gonna see is very gray sinuses, right? All these boxes with gray sinuses here. And on the right, what you see here is more black, and that represents air. And your sinuses are supposed to be full of air. They shouldn't be full of gray opacifications. Okay, well that's great. So our cystic fibrosis patients are having improved sinus CT findings. But what about their symptoms? Do they have improved symptoms? That's what this chart on the right shows. This is a questionnaire called the SNOT-22, which is basically this is a quantitative sinus disease quality of life assessment. So this is basically how many symptoms do you have from your sinus disease? How can we measure this? And what they show is that before highly effective modulators, their symptoms are up here for this SNOT-22, and they decrease substantially and they're sustained over time as well also. Sorry for that background noise. Apparently some of my house is printing a whole bunch of stuff while I'm in here. All right, so now we've talked about improvements in Pseudomonas colonization or chronic infection in cystic fibrosis patient lungs. We've talked about improvement in chronic lung disease as well too. But what are other additional promising data that we've seen in the past year as well also? What we've seen is that in a group of patients, sorry, what we've seen in this, what we've seen also is a very important group of patients who are left out from cystic fibrosis from a lot of these phase 3 trials are going to be patients with advanced lung disease. You know, a lot of times the studying criteria are going to be patients with an FEV1 between 40 and 90%. So what we're seeing, and so we don't have, so when we use these modulators in patients with advanced lung disease, we're actually extrapolating data. We don't have the direct data to say that this has been studied in that group of patients. But what we've seen over the past 16 months is that there has been an improvement in patients with advanced lung disease. And there's been several studies, observational studies, which have been published regarding this, and as well as post-market release data. The benefits aren't as great as regards to patients that have less severe lung disease, but they still are substantial. In addition to that, we have seen data that suggests there's a delayed time to lung transplant in these patients too. Now, 2020 data was confounded by COVID, and this is because you know, the most common indication for lung transplant is going to be COPD, typically in the United States, with cystic fibrosis patients being about volume being about 30% of the COPD lung transplant volume. But what we saw in 2020 was about a 50% decrease in COPD lung transplants and about a 75% decrease in cystic fibrosis lung transplants. So what that would suggest is that there has been a substantial decrease in lung transplants in cystic fibrosis patients since Trikafta was approved in 2019. I think we'll get more data over time once the COVID-19 mitigation effect has played out a little bit. But I think the early data would suggest that there is a delay in time to lung transplant too because of this improvement in advanced lung disease as well. Another question we commonly get in our cystic fibrosis patients is going to be, well, I feel great. My lung function is good. I'm not getting hospitalized as much. What studies do I not have? Like, which of my treatments do I not have to do anymore, right? These patients want to know that. And we, I guess, as a community, we hear you. We have the same question. We understand the burden of treatment is high, and we want to make it easier. So there is a study that's ongoing right now called the Simplify study. And in this study, basically, they're looking at two things. They're looking at what happens when we stop taking our Hypersal, or 7% hypersaline, and then what happens when we stop taking Pulmozyme? Is it better? Is there data that suggests that discontinuing one of these is better than discontinuing the other? Or is this not practical at all? I think it's important for patients and families to remember that the studies with Trikafta were done with patients typically doing their full treatment regimen. And when most patients are involved in a phase 3 study, they're actually on, I think we have additional data that shows that they're typically on their most adherent behavior during these study periods. But these studies are both enrolled. I think these are actually both fully enrolled last time I looked and are ongoing. So hopefully we'll have data in the next, potentially by 2021 with regards to this. Another thing too, I'm a pediatric pulmonologist, so not in my clinic as much, but in my adult colleagues' clinics, patients feel better. And one of the things they think about now that they hadn't thought about before was possibility of becoming parents as well too. And so that has led to now the study called the Mayflower study. And this is called the Maternal and Fetal Outcomes in the Era of Modulators. But this is basically going to be a prospective, multi-center observational study in women with CF who become pregnant while on modulators. So they're going to look at maternal health, obstetric outcomes, infant outcomes, and also the pharmacokinetics of modulators during pregnancy and lactation as well too. This is actually starting to enroll already, and it's expected to complete enrollment, or it's expected to start enrollment early 2021, and enrollment will be ongoing. But I think this is an exciting era now in cystic fibrosis patients. It's in the lives of cystic fibrosis patients, being how good people are feeling too. Another thing that's exciting are some of the expanded indications for modulators in 2020 and 2021. So let's look at some of these. So ivacaftor was approved down to 4 months. This was done in summer 2020. In addition to that, ivacaftor or Kalydeco mutations were expanded as well too. And this chart here, this table on the top right here looks at all the mutations now for which Kalydeco has been approved for. If you guys remember, initially it was for this guy right here, G55-1D, that second column on the right, third from the bottom, G55-1D was the initial one. And now it's been expanded to over 70 mutations. I've lost count, quite honestly. In addition to that, recently, and this was as late as November of 2020, Trikafta mutations were expanded too. Remember, in 2019, the original indications were for patients that were homozygous for delta F508 or had one single delta F508 mutation. Now it's been expanded to this entire table of mutations as well also. So this actually increases by a few percentage, I would say, the number of patients who didn't have they have at least one copy of delta F508. So this increases the number of patients now who are eligible for Trikafta as a modulator as well too. So this is exciting. And then I'm sure as many of the pediatric patients and pediatric families are aware of too, the FDA is currently reviewing the supplementary FDA data for Trikafta in ages 6 to 11. There was a press release from Vertex in September of 2019, right before NACFC, which said that it was both safe and effective in the 6 to 11 age group. And expected approval is due no later than June. So I think a lot of programs are already reviewing the patients who will be eligible based on the expanded mutations and getting ready to process those for approval. So I think that's exciting as well too. But what about that last group of patients, maybe 5 to 10% of patients who have what we call a nonsense mutation that doesn't make any CFTR protein at all. This has been a very challenging group. There's been elements, I think over the past decade, there have been brief episodes of excitement with the possibility of treating these mutations, and then other phase 2 and phase 3 studies have not panned out. One of the most promising studies right now is there's a therapeutic out there called ELX02, and this seems to help proteins. This seems to help get through those stop codons so they can produce proteins. And so the in vitro, which are going to be not patient studies, but in like still studies, basically are very promising. And now they're doing a phase 2 trial in patients with G542X, which is about a third, which those patients represent about a third of the patients with nonsense mutations as well too. So that's currently an ongoing phase 2 study. And people are cautiously optimistic that this will be as effective in vitro as it has been in vivo, or it will be as effective in vivo as it has been in vitro. Twisting my words there. All right, so now I've kind of gone back to 2019, reviewed the original Trikafta approval data, and also some of the real world studies that have come out since that time. And then I'm going to jump forward to 2020 with some of the other things that happened. So here's my transition slide for those of you who are Amazon shoppers like myself or who have become over the past year. And there's a frequent question that we get in our pulmonary office is going to be COVID-19 and cystic fibrosis. What do we need to worry? What do we need to know, right? So according to the CDC website, they say adults with the following conditions are at risk of adverse outcomes from COVID-19. This is going to be cancer, chronic kidney disease, COPD. I'm not going to read these, but solid organ transplant recipients. And I think a lot of us are familiar with these from various news articles as well too. I think if you notice here, what you don't see on this list is you do not see cystic fibrosis and you don't see asthma, which are both two that are very common conditions that are seen in the pulmonary clinic, right? So if you go to if you scroll down the CDC website about COVID-19, what you'll see is they say adults that might be at increased risk. And this is where they say cystic fibrosis might be on this list too. So I wanted to highlight that because I think that's important for families to realize. Initially, when they first came out with this list, cystic fibrosis was on it because basically the CDC had just extrapolated flu data for COVID-19. But as we gained more real world studies, which I'm going to show to you, it was kind of somewhat downgraded to might be at increased risk, which is reassuring. So what data do we have? This is a snapshot of a weekly email that I get and several other most providers get from the Cystic Fibrosis Foundation. And basically this shows us the amount of, on a weekly basis, confirmed CF patients with COVID cases here. So this is a busy slide, but what I want to show you that as of about a week ago, so February 11th, this typically comes out on a Thursday, there were 788 adult cases reported, 310 pediatric cases reported. Shows you the weekly increase as well too, so about 1,100 CF patients in the United States. As you notice from that 1,100, very few hospitalizations. And then if you look to, and this little asterisk I put down here too, is very few deaths also, 2 deaths, actually a total of 5 deaths in the United States, 2 of which were in advanced lung disease patients, and then 3 of which were in lung transplant patients as well too. In addition to those weekly emails we get from the Cystic Fibrosis Foundation, there have been some publications that have been done since this time. This right here is actually an international study, which was published in the Journal of Cystic Fibrosis in December of 2020, looking at the impact of COVID-19 in 181 people with cystic fibrosis too. Now, if you go back, if you look at that last slide, you're like, well, this is only 181 people. And your last slide said as of February 11th, 1,100 cystic fibrosis patients in the US already had it, right? That's a very good point. And that's because this is a peer-reviewed journal article. And I'm highlighting the important aspects from here, but this was based on patients who were diagnosed with COVID before June 13th, 2020, which seems like to many of us a lifetime ago. So this was relatively early on in the days of the COVID pandemic. So what we see here is about, this is from data from 100 June before mid-June globally of patients with this. This is a very busy table. It's easy to get lost in, but the things I wanted to highlight in this table is this group right down here, who this particular article identified at higher risk. This is going to be patients with moderate to severe lung disease, had increased risk of hospitalizations. Okay. Other data from this study, it showed that transplant patients were more likely to be hospitalized. Transplant patients were more likely to be in the ICU. Transplant patients were more likely to need supplemental oxygen. And then males with transplants were more likely to be hospitalized than females too. CFRD, so cystic fibrosis related diabetes outcomes, did not differ significantly than other ones as well too. And that's interesting because if you go back to that CDC table of adult conditions that put you at increased risk of COVID, diabetes is on there, but CFRD is not, is a hybrid diabetes, I think, as we all realize as well too, but CF patients with CFRD do not seem to be at increased risk too. And in this study, in this one, they had 6 deaths in 181 patients. And I think what's important to remember here is that this was a global study, which was done earlier on in the course of the COVID pandemic. And I think one interpretation of that is that the earlier death rate was a little bit higher, and before we had all the shared knowledge that we do now, we had the some of the treatments that we do now. So I think people are better at treating COVID than they were earlier on as well too. So if you look at those 6 deaths of the 181 patients, and you go back to what the US CF data is, that's 5 out of about 1,100 patients who passed away from COVID, and well below the population average. Well, that's great. This should be reassuring for people, right? Our CF patients are doing well. We thought it was at the beginning of this pandemic, we were all very concerned, and rightfully so. But the data seems to support that CF patients are doing well. So why is this? I'm not going to go into this whole table here, but and these are all speculative in nature, but one of the reasons is, well, people with CF tend to be younger than the relative population, so that might be protective as well too. I think one thing about the CF community is that we have an understanding of infection prevention and control strategies, AKA mask wearing. Most CF families have been wearing masks in the hospital environment for well over a decade now. So it wasn't a huge stretch for them to say, please wear a mask when you're out in public. I think it didn't have quite the it didn't have quite the people didn't have quite a trouble adopting it like they did in other communities that weren't used to wearing masks in public as well too. There is some speculation that maybe chronic azithromycin therapy and the anti-inflammatory effects of it helped with some of there were potentially some antiviral effects as well too. And then there's even some speculation that, well, maybe some of these CFTR, the underlying effects of having CFTR mutations as well may just make it less favorable environment for viral replication and other things as well too, and how infectious it is. And some of this is actually taken from some of the promising data that we're seeing from RSV in the recent years too. Taking a step away from COVID, what we've realized in the past, I think several years, have been several studies that have suggested that patients with CF who get RSV actually tend to do better than non-CF peers who get RSV as well too. And this is, again, counterintuitive and not what we've thought in our community for a long period of time. So there do seem to be some similarities between these two groups. All right. Well, that's excellent news, right? I think it's really exciting to know that CF patients are doing well with COVID infections in the United States. But let's talk about more good news. Now, I guess again, it seems it hasn't been that long ago, but 2 months ago, just over 2 months ago, we had finally FDA approval or emergency use approval in the US for COVID vaccinations too. And that's what I want to spend this next segment talking about, because I will tell you that in my own CF clinic, I get a lot of questions about COVID vaccinations lately. And then I know that our nurses are getting several phone calls per day about COVID vaccinations as well too. So I want to talk about this because there's a lot of misconceptions out there. So first off, I'm going to go way back to basics. How do vaccines work? Okay, this is grossly oversimplified, and I stole this from the CDC website, but basically, remember, a vaccine, they inject a weak form of the disease into your body, and your body makes antibodies. So when it actually sees this infection, it's ready to attack them and destroy them, okay? But basically, it trains your body to fight in a war, okay? That's the essence of how a vaccine works. What are side effects of vaccine? Usually they're very mild and they're short-lived. So sore arm, all of us have experienced, maybe a fever, but very short-lived and not long-standing. People have lots of concerns about long-term health problems. We have well over 50 years of observational data that's been observed since over multiple types of vaccine in multiple children and in adults. We don't have any data to suggest that vaccines cause long-term health problems. The side effects tend to be relatively short-lived after the actual administration of the vaccine. Are vaccine ingredients toxic? Well, there's been lots of stuff as well too. I would say that any substance can almost be toxic in high doses. You think about something like Botox, which people get for wrinkles and sweating and other things, that can certainly be toxic. To play devil's advocate, drinking too much water can be toxic. But yes, there are chemicals in vaccines which, at taken at significant doses, could potentially be considered toxic, but they're generally not considered toxic in the doses that they're in vaccines. Okay. All right, this is supposed to be like a skeptical slide. Well, how was vaccine development timeline accelerated so quickly with COVID? I think it's funny to point out that actually when I was driving my 13-year-old to school the other day, her question for me was, why did it take so long to develop a vaccine? She said, it's been a year, and she rolled her eyes. So I think perspective is important here too. But how did this happen so quickly? Well, basically, we were able to use existing clinical trial networks that were already in play in the United States as well, too. They were able to pivot from other studies to get these other trial networks important, given that we're in a public health emergency. I think it's important to note that drug manufacturers, vaccine manufacturers, started manufacturing vaccines while clinical trials were underway. Normally, this would be a horrible idea because you wouldn't want to spend billions of dollars manufacturing vaccines, but basically they were giving financial incentives that said you won't lose money if you do this vaccine, because they understood that it was important to get ahead of production schedules. So in essence, they were hedging their bets a little bit. So because if they hadn't started making the vaccines and mass producing them while they were doing these studies, we'd be about 7 to 8 months behind where we are now into production scale. As most people have seen on the news, we're not where we need to be also, despite this 7 to 8 month head start in essence. Some of these new vaccines, such as mRNA vaccines, are actually faster to produce than traditional vaccines. And I'm going to talk about the 2 mRNA vaccines that are currently approved. And then in addition to that, FDA and CDC prioritized review. So they said, we need to look at this stuff before we look at other things. This may be one of the reasons that, I'm just speculating here, but this may be one of the reasons that Vertex waited to submit the Trikafta data for 6-11 to the FDA, because we're in a public health crisis right now. And they understood that the FDA is prioritizing other things right now. And a lot of patients were like, families were like, why isn't this there? We had the press release was September, and this may be one of the practical reasons why Trikafta and 6-11 hasn't been submitted until January. I think our CF patient is pretty familiar with studies. We're a pretty actively engaged population, but just, I just want to remind people of the various phases of studies. And what I want to show here is that, that these vaccines went through all the normal phases of clinical trial phases that everything else goes through. There were no shortcuts taken in clinical trial phases. I think that's important for everyone to understand. Another term that gets thrown around out there a lot is an EUA, Emergency Use Authorization. So what is an EUA? What does this mean? Because people hear this in the news. So this is a mechanism that facilitates the availability and use of medical countermeasures, including vaccines, during public health emergencies. But I think it's important to note that this only lasts as long as the public health emergencies, and that all of these vaccines that are approved through an EUA will have to go through the formal approval process. So what does that mean? This means that the FDA says, we are in trouble. We need to get these approved quickly. The data looks really good, but we're still going to formally approve it. So in the meantime, this is a shortcut in order to do it. The data is still closely reviewed by public health experts and people familiar with data analysis, and it will go through a formal approval process. This is one of the reasons that employers, healthcare employers such as where we ourselves, the COVID vaccine was not a mandatory vaccine for us. I can tell you our entire CF team chose to get it, but it wasn't mandatory. And it's not mandatory because it hasn't gone through the formal FDA approval process, such as the flu vaccine. I imagine, I don't make policy at the hospital, but once it does go through that formal process, I suspect that it will be a mandatory vaccine for healthcare workers, just like the flu vaccine is every year. All right, now I've kind of given people an overview of the clinical phase trials, given people an overview of what an EUA is. Now I want to talk about some of the specific COVID vaccines and then what I'll call the candidates that are out there, just because I think this is out there in the news a lot right now. And on social media, there's a lot of misinformation out there. So and just to go back real quick, these are kind of the 6 big players. We'll talk about 4 to 5 of them. I'm going to go in order of approval in the United States. So the first, as you guys recall, back on December 13th, 2020, the Pfizer-BioNTech COVID-19 vaccine was approved for EUA in the US. This is an mRNA vaccine. It has the code for a spike protein, which helps COVID gain entry into the cell. Okay, so basically what this trains your body to do is prevent antibodies that will prevent entry into the cell. And this was approved in patients greater than or equal to 16 years in the United States. And this will be important in a few minutes. what are mRNA vaccines, right? This is relatively new to most individuals out there. So basically an mRNA stands for messenger RNA, and this takes advantage of the process that the cells use to make proteins. So normally DNA gets transcribed into RNA, and then RNA gets translated into proteins. So with these vaccines, what they did is they said, let's make the RNA so we just can skip the transcribing process and we can go straight to translating. And so it takes a shortcut, okay? Common questions we get about these vaccines are, do they enter our cell nucleus and interact with our DNA? The answer is no. It's not a live virus either. And there's no risk of causing disease in individuals who are vaccinated also. This technology has actually been over a decade old. It's been studied in influenza, Zika, rabies, CMV, which is as well too. And I think it's important to note that this study is this technology is over a decade old, but there have never been quite both. I think there's been two incentives which have really pushed. We're able to help fast track this vaccine into current vaccine utilization, and that's both the public health emergency we're in, and then the specific financial incentives that the U.S. government put into this. Really, both were. I mean, if you give people enough money, they will come up with solutions. But things like Zika and rabies, there's clearly not the financial incentive to produce vaccines for, sadly enough. What's the efficacy and safety about that? And by efficacy, I mean how well does this work? So the Pfizer vaccine, this is going to be 2 doses, 21 days apart, okay? And what you see is after 7 days after your second dose of the Pfizer vaccine, so 28 days after your first dose, okay, or after your second dose, so about a month after you started the sequence and finished it, it's 95% effective, okay? What did they say? Well, basically in this large study, they had 8 cases of COVID, symptomatic COVID in the vaccine group, and they had 162 in the placebo, okay? They do have some basic data which suggests there's only 55% effectiveness after 1 dose. And I think this highlights the importance of completing the series. This data is somewhat, you have to be cautious in interpreting this data because these studies were not set up to truly evaluate 1 dose, okay? The other important thing too is while there were 8 cases of actual symptomatic COVID in the group who received a vaccination, they had 0 cases of severe illness, so 0 hospitalizations. I think that's important. I think a lot of us have heard about the side effects from the COVID vaccine. And I can tell you from my own personal experience that after the first vaccine, I had a sore arm, and that was about it. But after the second vaccine, I did have a fever. I was a little tired for a day. And those were my only symptoms. Other people commonly report headache and muscle aches as well too. And while I did have a low-grade fever and I felt pretty tired, I haven't had COVID. I'm pretty sure it was better than having COVID. And it was very short-lived, and I was better by the next afternoon. It's also very safe as well too. This table on the right of my screen here, this was published in the New England Journal of Medicine in January 2021. And what this shows here is this is data that was going back and looking at the original phase 1 trial participants and looked at specific antibody levels. And what this shows was after 120 days after their initial vaccine dose, they had sustained antibody titers in their bloodstreams, which shows that there was a sustained effect. Antibodies are just part of the story about how your body fights a viral process, but I think it's one of the easiest things we can measure in the clinical world or in the research world as well too. So I think that's important. So we talked about the Pfizer vaccine. Shortly after that, only 5 days later, the Moderna vaccine was approved as well too. And this is very similar to the Pfizer vaccine. It's also an mRNA vaccine. It's approved for individuals 18 years and older. The doses are 28 days apart, and similar to that 95% efficacy, this is 94% efficacy too. I have a little table here that shows the difference between the 2 vaccines. I'm just going to highlight the differences because a lot of people, there seems to be a lot of confusion between the 2. The group on the left is the Pfizer vaccine. The group on the right is the Moderna. For Pfizer, I circled it's approved for 16 and older, and Moderna is 18 and older. There seems to be a slightly lower efficacy in the Moderna vaccine of individuals older than 65. That doesn't pertain to a lot of our community here, but some of our caretakers, it might. The vaccine days are different. Pfizer's 21 days, Moderna's 28 days. And then the storage requirements are different. Pfizer does require that ultra cold refrigerator that's at -94, whereas Moderna requires just a typical freezer, which is at -4. So I think there's a lot of practical implications for where you might be able to deliver these two vaccines at. The Pfizer vaccine would require more infrastructure to distribute it as well too. So I think those are important things to be aware of. So technically, if we actually go back globally, the first approved COVID vaccine was actually the Oxford AstraZeneca vaccine. And as people recall, I think it was about 2 weeks before the Pfizer vaccine was approved in the United States, the UK approved the Oxford AstraZeneca vaccine too. And right now it's approved in Britain, India, and EU, and it may have expanded since I wrote this slide about a week ago. This one is actually an adenovirus vaccine. It takes a chimpanzee adenovirus, which adenoviruses are common viruses that are common in nature and cause various degrees of infections in humans. But they took a modified chimpanzee adenovirus that can get into the human cells but can't replicate inside them. And basically what they did was they put the DNA for the coronavirus spike protein in there. So you have to go, as you see in that slide on the right, it goes from DNA to mRNA to protein. This was actually not the first adenovirus vaccine approved. Quietly during the middle of the pandemic in July 2020, there was actually a adenovirus vaccine approved for Ebola as well too, which is also a concerning infection as well. The Oxford AstraZeneca thing, a few things I want to talk about is what are the benefits of this vaccine? Well, DNA is less fragile than RNA. So I think logistics for distribution and storage are easier and cost is lower with this vaccine. So this one can last at 6 months when just refrigerated at 38 to 46 degrees Fahrenheit, which is vastly different than -94. Also, like the other ones, 2 doses, 28 days apart. This one did have a study quirk, and people may have heard about this on the news, but in essence, there was an error during this trial where some of the volunteers only got half the dose of the first vaccine as opposed to 2 full doses. And then what they found was the group that had the half dose in the first vaccine seemed to have a better effect than people who received the 2 full doses. So the UK advisory committee was okay with this study quirk, but I think the US FDA, given that we have 2 effective mRNA vaccine trials, 2 mRNA vaccines approved under EUA, aren't going to be quite satisfied with their explanation. So there are still US trials that are being completed to look at the 2 full doses. And I think it's important to know that the US is being very transparent in how they're viewing these. So that's why this vaccine is not approved in the US right now. That study quirk has a lot of people would like to see a more systematic study without errors in it. People have probably heard about this one in the news lately, and if they haven't, they will be very shortly. The Johnson & Johnson COVID vaccine. Again, this is very similar to the Oxford AstraZeneca vaccine. This one does something very similar. It puts DNA inside adenovirus 26, which is a human adenovirus, but just like the chimpanzee one, get into your cells, but it can't replicate or cause illness. This one's unique in that the phase 3 study that was done here was a 1 injection study, and the results were released January 29th. So the press release was January 29th. I have not seen our literature on this. This is all based on press release. But what they said was that 66% effective in preventing moderate to severe disease and 85% in preventing severe disease. But there was also complete protection against COVID-19 related hospitalization and death. And I think this is important to know because I think a lot of people see the numbers of 66% and 85%, and the impression may be that this vaccine is not as effective as the Moderna or Pfizer vaccine. But I think it's important to know that what we're trying to stem here are hospitalizations and deaths across the country as well too, and long-term morbidity, and it does a good job at that as well. And then the implications of a one-shot vaccine are so much more practical than trying to get two shots. Two shots is a much more different logistically when you're looking at 300 million Americans to vaccinate. There is another phase 3 study out there that is actually looking at two doses because they want to know, are two doses better than one? How much better? Is it worth doing two doses? But this one was studied to do a one injection vaccine. So I think this one's too. This is actually going to be evaluated by the FDA for emergency use authorization next week. So I think that's next week, February 26th. And it's expected, unless there's something we're not aware of from the press release, that this will likely get approved and could be approved as early as March, and this one could be out in the community too. And also, I think it's important to note that Johnson & Johnson has a long track record of manufacturing, and so I think that their logistical infrastructure will be very important too, as opposed to Moderna, which was the first product they actually brought to market. Okay, there is another one out there a lot of people haven't heard of yet, but they probably will hear of it in the not too distant future. But this is the Novavax vaccine. And this is a more traditional vaccine. So it's not an adenovirus, it's not mRNA. It's actually it's a protein-based coronavirus vaccine. It's two doses. And the short of the story is it's similar to influenza and HPV vaccines, where it's created by protein harvesting from specific moth cells, and then these proteins are injected into you and they create that immune response. So remember, these mRNA vaccines trick your body into making the protein for them, and this way they inject the protein into you. This is phase 3 studies are ongoing right now. They finished enrollment at the end of December in the United States, and we expect data from these studies in the coming months as well too. But the phase 2 data looked very promising. So this could be a fourth potential vaccine candidate as well too. All right. One of the things I hear in CF Clinic is patients have some of the concerns my patients have expressed to me is, well, gosh, this happened really quick, and how big were these studies? So the reason I put this slide in here, and I actually put this in here today, and this was based off of a patient interaction yesterday before we closed down for snow, was to help gain perspective. So on the left here, I have the Trikafta phase 3 study. So just to put it in perspective, in the United States, we have about 30,000 cystic fibrosis patients. When Trikafta was approved, so the homozygous Delta 508 country study looked at was four countries, 113 participants in 4 weeks duration. The minimal function Delta 508 study was done in 13 countries and had 405 participants. And as I showed you earlier, the data had 24 weeks duration. Let's compare that to the COVID phase 3 study. So for Pfizer, it was 6 countries, over 40,000 participants in 17 weeks. So that's impressive. That's more participants than there are entire patients with cystic fibrosis in the United States. Very similar with Moderna. Moderna was specifically done in one country though, but 99 sites within the United States. And then Johnson & Johnson too. I couldn't find the data on how many, just because it was based off a press release. I couldn't find how many countries and how many weeks yet, but over 44,000 participants. So I think if you add up those together, that is well over 100,000 participants in just these 3 vaccines. So I think people should feel relieved by the amount of participants there were in these studies. All right, well, I'm a pediatric pulmonologist, and a lot of you are parents or grandparents out there. So what about kids in the COVID vaccine? Well, right now, Pfizer's the only approved vaccine in pediatrics, and I would say barely approved, right? Because they're only approved for 16 and above. But they are fully enrolled in the study to 12 to 15-year-olds, and they have plans to expand and enroll ages 5 to 11 later this year. Moderna is currently enrolling ages 12 to 17. They started that about 2 months ago in December of 2020. This was just released in the news recently, but Oxford AstraZeneca study is actively studying 6 to 17 years old in about 300 patients. And Johnson & Johnson is expected to enroll pediatric studies in the spring too. Typically with pediatric studies, you're not going to see the robust numbers that you do see with the adult studies. But what they want to do is they want to show that they're safe. One of the challenges they may face is, I think one of the challenges that they expect for them to face is that children tend to have less symptomatic disease, less risk of hospitalization. So it's going to be important long-term to control COVID spread within pediatric patients, but we want to make sure that these vaccines are safe because children don't get hospitalized with them. But this is and for those of you who have been following approval of highly effective modulators, this is very similar framework to how these modulators are approved. Typically, they're going to be older adolescents and adults, and then they start making their ways down to the younger populations. And these vaccines are going to use a very similar framework as well too. But long term, most of us believe it will be important for children to get vaccinated, because a lot of times they do have asymptomatic spread of virus to at-risk family members. So they're going to be important. It's going to be important to control spread in that age group. All right, so now we've talked about kids. Now, where does CF fall in the vaccine hierarchy, right? Oh boy, this gets confusing. So I'm put in 2 states here because most of our patients are from Missouri and Illinois. So if you're from another state, I apologize, I left you out. So in Missouri, they have 3 phases, and they have subsets and tier subsets. So they have 1A, which is typically the patient-facing healthcare workers. Then they have 1B, they divide into 3 tiers, phase 2, phase 3. I don't know why they just didn't number it 1 through 6. It would be much easier. But in Missouri, CF seems to fall into phase 1B tier 2. I will say, for instance, in St. Louis County, I put this up here. This is from the St. Louis County COVID vaccination page. Cystic fibrosis is specifically listed as a condition, as a high-risk individuals, but St. Louis City, it is not. Illinois does things a little bit differently. They have 2 phases, and they have subsets in tier 1, so a little bit different than Missouri. So they have 1A, 1B, 1C. In Illinois, it seems to be a little bit of a gray area, but it seems to imply that CF is in 1C. And when you're on the Illinois website and you click the hyperlinks, it takes you to the CDC page, which goes to the might be at increased risk. So it's a little bit vague. So I would advocate for people to check their local counties vaccination page as well too. I do think it's important to know that despite the even though the data has been reassuring for the CF population, the Cystic Fibrosis Foundation has been actively advocating at both local and national levels for COVID vaccinations for CF patients, and you can see this on their page too, of the various letters they've sent to state vaccination committees. They've sent one to President Biden and other ones too. So they're actively advocating for the CF population too. What about some specific scenarios? Things we get asked, what if I had a COVID infection? What if I already had COVID? Typically I say get it still. Reinfection is very uncommon in the 90 days after the initial infection. So it's probably safe to defer till the end of this period. And then if you had COVID infection, you received passive antibody therapy, then you should defer 90 days is what the general rule is. What if you actually have COVID right now, or you have a known exposure? Well, you should wait until you actually recover from your acute illness and you actually have met the criteria to discontinue your isolation so you don't get other people ill. And then the other question is, if you're exposed, it depends on the setting of exposure too. If you're in a setting where you may get exposed over and over, you should probably get it. So if you're a member of a long-term care facility, that you're probably going to get exposed over and over, they generally say, despite your exposure, you should get the vaccine. If you're someone who would infrequently get exposed, then it may make sense to wait till the end of your quarantine period. What about immunocompromised, pregnant, or breastfeeding population too? There's not a lot of safety and efficacy data in this group. However, this group's considered high risk, and most experts believe that the benefit of getting the vaccine outweighs any potential risk. And there are going what they call DART studies, which stands for developmental and reproductive toxicology studies that are ongoing too. All right, great. Now you've told me where CF is in the hierarchy. You've told me about specific scenarios. Where can I get a vaccine, or where can my child, or where can my spouse get a vaccine, right? Well, this is extremely confusing, and it varies. I think it's been the problem with the whole response to COVID in general. This is a very patchwork system across the United States too. So this really varies by both geographical and healthcare system, and is a rapidly changing landscape as people see on the news. So what the most practical advice I can give for people is most, you know, start by enrolling within your local county. A lot of times county will ask if they'll list it to see if you're in specific risk categories. Then presumably what's going on is they're triaging that to the various phases and tiers within those phases. And then the additional one too is the healthcare system that you receive primary or specialty care from also typically has online registers as well too. I know we're doing that at SSM and SLU Hospital as well too. We're starting to gear up to vaccinate our eligible cystic fibrosis patients as well too. That's an ongoing project as well too. So it is very frustrating, and I think it's for a lot of people who are eligible. What about what about COVID testing after vaccination? So if just a few questions I've had in clinic also. What if you get the COVID vaccine and then you get sick and someone has to test you? The COVID vaccine itself will not affect the viral test. So either a PCR or antigen test. However, if someone orders an antibody test on you, it may be positive after infection or vaccination, and it depends on the antibody test. So I think antibody test, we've been using them somewhat to find out if people have been infected in the past. I've used this in my own cystic fibrosis population, but I think once vaccination is widespread and people have been vaccinated, an antibody test is not going to be very helpful in determining if you were previously infected. But it's important to note that it will not change the results of a viral test because none of these vaccines cause active disease. What vaccines do not change right now. So once we are eligible to get them and we get them, as of now, you have to continue to wear masks. And because I think it's important to note, those studies only looked at symptomatic individuals, people with severe disease and hospitalization. It didn't look at, and it did not, those studies did not look at, did you have COVID at all? Were you contagious? So those studies cannot answer those questions. We have to continue to physically distance for now. And I already said the vaccines are good at preventing serious illness. So I think it's important to note that despite all the promising news on the horizon, it's important to maintain our guard up and not to become complacent, right? Like this is a perfect picture of complacency, this little deer drinking next to the watering hole, right? So I guess that's it for my presentation. I want to thank everyone. The reason I put this slide on here was during my old operational medicine days in the Navy, I worked with and took care of someone who ultimately ended up having cystic fibrosis when I was in one of these aircraft. So, and him and I still keep in touch. And he was actually in the original Kalydeco studies back in the 2010 period because he was a G55-1D. So I will leave it open for questions if there are any. I'm sorry if that went a little long.
No, that was excellent. Thank you very much, Dr. Smiley. You did such an excellent job addressing the questions that came in prior to our call tonight. If anyone has any further questions that didn't get answered, please type them in the Q&A section now. Please do keep your questions general so we can't provide specific medical information on this call. And you would want to consult your care team with any personal medical questions. So one question came through, going back to ELX-02, do you anticipate this being available for trial study for those with a frame shift class 1 mutation? Everything they've seen so far has been grouped nonsense mutation. And do you think it'll become available for those other class 1 mutations in the future?
Oh gosh, yeah, that's a great question. I think probably it depends on how it goes with the phase 2 studies, and I think it probably depends on how it's going with those phase 2 studies.
That answers the only question that came in advance. I'm going to give it one more moment to see if anybody else asked. I think you just did such a phenomenal job of covering everything that you may have gotten them all.
And I see one question on there. It says Susan Ritter to panel. Okay, there it is.
There we go.
Well, telling them to sign up for the vaccine, there's not a bubble to fill in. Yeah, so I think for Susan here, this goes to that the fact that CF kind of falls into this gray area in a lot of these algorithms based on how the CDC has classified it. So, I think it would be reason if you one option, and I haven't tried to fill these out for I haven't tried to go on and fill these out, but you might be able to select a condition for chronic lung disease, which would not be an untruth because it is a gray area. But yeah, so for instance, yeah, St. Louis County, it is a specifically listed condition. But that was when we did some research as a team on this, just through some, we were going to the various counties' websites and looking. It was St. Louis County was one of the very few that actually had it specifically listed. A lot of the websites don't specifically list or not listed as a condition. So I think I would potentially, if I was in that position, I would potentially fill it out as maybe like a chronic lung disease and try that.
Okay, we have another question that came through the chat. Are trials scheduled for Trikafta in an age range with 18 months to 2.5 years old range yet? Any site be in the St. Louis area?
Yeah, typically the next after the 6 to 11 is typically the next age range they look at. It's going to be 2 to 6 years. They have a pretty tried and true algorithm for how they march a lot of these medications down to the younger population. So typically after 6 to 11, they're going to go age 2 to 6. And we don't have that right now, but I imagine that with 2 large CF centers in the St. Louis area that we would all be hopeful to be part of those studies. So, so keep monitoring that on the CF website for active studies. But
just a few more moments in case anyone is typing, but I don't see any other questions at this time. I think that wraps up our presentation for this evening's call. I just want to say thank you so much to Dr. Smiley for his time and sharing his knowledge with us tonight. And thank you to all of our local care center teams. Every year we rely heavily on them, and they've been working so hard to provide telehealth and the highest level of care during such stressful times. So we hope you'll join us again for our next CF community chat in Q2, and the date and time or to be determined still for those calls. And if you wouldn't mind just staying on with me for 2 more minutes, I wanted to share briefly our upcoming events we have planned here at the Gateway chapter. Spring Hike this year will be a 65-day challenge from March 5th to May 8th, which is a great opportunity to meet others virtually who are connected to our cause and to participate in a fun physical challenge. You can set your own personal hiking challenge, whether you're a novice or experienced hiker, and all are welcome. Also, our Spring Great Strides Walk has been reimagined. It is now Great Rides Car Parade, and that will be held at the Worldwide Tech Raceway in Madison, Illinois. So we hope you'll get your team registered and join us on May 15th for a safe, socially distanced, fun time at the racetrack. I believe there is another question that just came through.
I was just about to sign out. Good timing.
Can you field that one? You want me to read that?
Where do caregivers fall in the tiers? You know what? I'll be honest. I haven't had the chance to explore that carefully yet. That's a good question. So I don't want to answer speculatively on that one. So.
Jump back in. We do have a few more virtual calls coming up as well that we'd like to share with you. Our Grampian Social Hour is coming up on February 24th. And another great opportunity to learn about CFF and all the work we are doing and meet some incredible volunteers and CF grandparents. So this is a great group of folks. On Thursday, February 25th, you can join us for a mixology event where we'll be mixing up some St. Patrick's Day themed drinks and also playing a game of trivia. These are really fun calls and always well attended. And last but not least, we are hosting a call on Tuesday, March 2nd at 6:30 for those who want to make a difference with their support and fundraising efforts in 2021. Hearing from some of your peers and how they pivoted their usual fundraising efforts and saw success during this uncertain time. So while we can't be together in person, we sure have a lot of fun virtual events and calls upcoming. And the best way to stay connected with us is through our social media channels, which are listed here. We'd also like to mention that we send out a chapter newsletter via email every month, and we hope you are receiving that from us. If you aren't and would like to, please email us at gateway@cff.org, and we'll be sure you start receiving those from us. And as a staff member at CFF, I can't tell you how much we have missed seeing our CF community this last year, our volunteers, our families, and our corporate supporters. And we are so looking forward to 2021. And while we can't promise what it's going to look like exactly into summer, fall, and winter with our events, we can promise you that we are dedicated and will be as creative and innovative as possible to keep engaging and fundraising. So please reach out to us if you have any questions, suggestions, or just want to say hello. We'd sure love to hear from you. And that wraps up our call for tonight. Hope you stay warm and healthy. Thank you again so much, Dr. Smiley, for joining us. Everyone, take care and be safe.
Thanks for having me. Bye, guys.